Well, hello and good evening. Oh gosh, my mic is over here. Holy cow. Let's try that again. Hello and good evening to everyone. It is 5 o'clock on the Gulf Coast, which means 6 o'clock in the East and 4 o'clock in the West. There is one place that you are supposed to be right now, and that is right here. It is time for Fertility with Fink and Friends. I am Fink, you are Friends. And as always, this is the place we come every Tuesday at this hour to talk about fertility, to talk about women's health, to talk about making families, talk about getting pregnant, and all those things that are important and on your mind tonight. And I am so glad to be here. Last week was vacation week, and appreciate all of the very happy wishes that I got for there. And if you showed up here looking for me, I appreciate that. And sorry we didn't get to see you, but we are back now. Hey, it's election night tonight. Did you know that? Election night. I hope everybody had a chance to vote, exercise your constitutional right as a citizen here, and go out and vote if you haven't already. Polls are generally open until 7 o'clock p.m. wherever you may be. Let's see. Oh, there we go. We started to lose a connection. Well, we've got a bunch of different feeds here tonight. I've got my Instagram right here, which is Randy Fink MD. Here is New Life Fertility. We also have Facebook, YouTube, Instagram. What else? LinkedIn. For New Life Fertility, we have for MCRM, and we have for the First Fertility Network. I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida, as our home base. We also have offices in Mobile, Alabama, as well as Panama City, Florida. Home base here in Pensacola. And I also work with the fine folks at the Missouri Center for Reproductive Medicine. That's MCRM in St. Louis and in Tulsa. Great group of people. So no matter where you are, we are here to help you. We can do virtual consults. We can talk to you over the phone or over video. We can help you in your cycle no matter where you are. So how's the week going? How was your weekend? Special shout out this evening to Kowser. It is good to see you two here, my friend, who said hello, and you were number one. Actually, I'm lying. Rich, you were number one. Kowser, you're number two, but you're never far from my heart. Hi to Henry over there. Thank you for joining in. I can't see who you are on the Facebook, LinkedIn, YouTube side, but I see there's a bunch of folks already on there. So feel free to throw out your questions tonight. That's what we're here to do. Hi, Rosa. It's good to see you here as well. It is my pleasure to spend my time with you. Rosa has a great story. Rosa is, I think if I'm not mistaken, you're 44. Rosa has I think I'm right on that. Rosa has a large endometriosis collection in the ovaries, and that's called an endometrioma. And Rosa went through IVF, did several embryo transfers, and ultimately ended up pregnant, which is really one of it's a beautiful story. And I hope that Rosa, you're sitting there tonight holding your baby, because we think about you here and all that you were able to accomplish. A very special shout out going across the pond to my dear friend Bailey and Cameron, who are now in England. It is such an honor to have you here. Plus, I think it's also like midnight or something in England. But thank you for being a part of my day today. You brightened up my day. It was really great to see you. Cameron serves our country for us, and they have relocated across the sea to England, where they are now. Just got there a couple of days ago, and I'm very excited, very, very excited for you, but especially excited for all the things that your future will hold. And like we talked about, yes, it most certainly does. Dr. Noreen, thank you for being here this evening. A pleasure as well. Also very exciting times for you there, my friend. Rosa says, very grateful for you and all your advice. It's my pleasure. Kowser says, I'm 11 weeks pregnant. I forgot that you said that you were pregnant, and I think, oh my gosh, that is fantastic. My doctor says I don't need an NT scan since I'm doing genetic blood work? Is the blood work alone enough, or would you still recommend the NT scan? Well, so the NT scan, NT stands for nuchal translucency. The nuchal is the neck translucency. And what we do with that is that we measure the thickness of the baby's neck. And that can be plugged into a formula that identifies risk for certain types of genetic problems. It is really looking for something that's called a cystic hygroma, which is a type of a birth defect that you can see in a baby really as early as 11 or 12 weeks. So it's usually measured, kind of between 11 and a half and 13 weeks. Classically, the NT was measured in order to plug its measurement into a formula so that we could actually get a calculated risk back for risk for those types of genetic problems, specifically things like Down syndrome. Nowadays, it's often used differently, and I suspect, their counselor, that you are going to be doing what's known as NIPT, and that is non-invasive prenatal testing. Non-invasive prenatal testing is, so in the olden days, moms who were older than 35, we would say, oh, you should have an amniocentesis. And an amniocentesis is where you take a needle and you place it through the wall of the uterus, usually, and suck out some of the fluid that's surrounding the baby. That fluid that's surrounding the baby has the baby's cells. They're sloughed off skin cells where you can actually test the chromosomes of the baby. You get that information, and that tells you that your baby is chromosomally normal. Now, NIPT is where some wise person has figured out how to take a tube of your blood, counselor, right from your arm there, a tube of your blood, and shake it up in such a way that it separates out your cells from the baby's circulating cells within your bloodstream, which is really pretty fascinating. It's amazing stuff that they're actually able to do that. So mom has baby cells circulating through her blood, and we can separate those cells and can probe those cells specifically for trisomy 13, trisomy 18, and trisomy 21. 13 and 18 and 21, trisomy 21 is Down syndrome. And we can, it's not technically a diagnostic test, but the results of that test are very, very highly accurate for those conditions, and can usually tell you boy or girl as well, with a very high degree of sensitivity. Well, if you're testing for Down syndrome through NIPT, then technically speaking, the measurement of the nuchal translucency is really not critical. So your doctor is absolutely right about that, because that number doesn't have to go into a formula that is going to calculate a risk that is far less accurate than the NIPT itself is. However, checking for thickness of the baby's neck is usually something that's done towards the end of the first trimester anyway, evaluating sort of even qualitatively what that looks like. I think is an important thing. But it has always been that in order to be able to take that measurement of the nuchal translucency, you had to be certified. You actually had to go through a certification process. You had to submit images to the certification board. I had done this certification back when I was practicing OB. And you actually had to be certified for it. So now I would say the precise measurement of that nuchal translucency is really not critical for you in this case, counselor, because you're doing the NIPT. And the NIPT is just a more sensitive test than the one that required the quantitative measurement of the nuchal translucency. However, certainly makes sense to say, hey, have an ultrasound around 12 weeks. Just take a look at it, make sure that grossly it looks normal. I think that's a very reasonable thing to do. Now, some OB practices don't like to do that. They like to really try to limit the number of ultrasounds. There is no science that says, I take that back. The American College of Obstetricians and Gynecologists says that there's no reason to do unnecessary ultrasounds. All right. I buy that 100%. But in almost all cases, an ultrasound you can find a necessity for. Now, that doesn't mean that you need to do an ultrasound every week. That doesn't make a lot of sense. But I think having a first trimester ultrasound is a good idea. I think having one at about 12 weeks or so kind of makes sense, so that you can look at the thickness of that neck. And then, of course, the next one that you'll do is going to be the anatomy ultrasound. That's typically done between 16 and 20 weeks. Your baby is 14 centimeters for 11 weeks. I think you're talking about really what we call there a crown rump length. And that's a measurement from the top of the head to where the butt is, the rump. Gosh, I think that sounds about right, but honestly, I don't know. I usually plug it into the computer. The ultrasound gives me the measurement and tells me kind of what the percentile is, but that sounds pretty good. A special hello to Zenny in sunny South Florida this evening. Hello, Zenaida. Thank you for being here and brightening up everyone's day, as you so often do. It's great to see you here tonight, and I hope you voted as well. I will be going to the polling place at the conclusion of Fink and Friends tonight because it is our civic duty. We are lucky, honestly lucky, to be able to go out there and vote. So I really strongly encourage you. Go do it. It really makes a lot of sense. Rosa says, I started to have my periods while I was still breastfeeding. Does this mean that after weaning, I still need to suppress with Orilissa before trying another frozen embryo transfer? Well, I will tell you, most of us who are taking care of breastfeeding moms can say that really after about 6 months of breastfeeding, that you may return to normal ovulation, even though the breastfeeding aspect is suppressive on the hormones. So there are some people who, while breastfeeding, will not get a period at all, but many people will just kind of start to get a period. And after about 6 months, really you kind of return to sort of normal fertility. We used to really kind of feel like, breastfeeding is really protective on pregnancy. And it's not. So breastfeeding is not a method of contraception. So don't make that mistake. Certainly by 6 months, you're probably ovulating again. So many people will start to have a period again, even though they're breastfeeding. Given your history of endometriosis and the fact that you still have some endometriosis collection in your ovaries, Rosa, and that's called an endometrioma, I would suggest that you probably do suppress again before doing another embryo transfer. And why is that? Well, in fact, let's see. It says there's fuzzy noise in the audio. Maybe that's a little bit better. Is that any better? Thank you, Stephanie, for pointing that out. That may be because I think I know why that is, but I moved the camera over a little bit and hopefully that makes it a little easier. Did it help? Boy, I lost my train of thought there. Thanks for that one. Don't know where I was going with that. Breastfeeding. We're talking about breastfeeding and suppression. These embryos that you have, they're very precious. And so I wouldn't take the chance, since we know that you have endometriosis, I would suppress for that 2 months before doing your transfer, irrespective of whether you got a period or not. That's just my opinion. Hi to Aaron out there. Good evening, Aaron, recovering from surgery here tonight, as well as Midgie, who is hopefully not recovering from surgery tonight. And Aaron, by the transitive property, hello also to Z and to Luca. How about that? And to your grandma. Hi to everybody else out there. I hope you are having a wonderful Tuesday, that your weekend was good. I don't see that the Bama gal and her husband, that is my wonderful mother and father in Mobile, Alabama, I don't see that you're on here, but the last time I didn't see you're on here either. And I do want to give a special shout out to Mom and Dad, because Mom has been very, very sick, back in the hospital. Had a little incident with the old heart wall there and the blood vessels, but seems to be on the mend. So happy to hear that, and I know all my friends out there watching tonight will want to send their warm regards your way as well. So, Mom and Dad, if you're watching, thanks for being here. Let's see. I got a question here that came from. Oh, thank you, Doctor, for sending good vibes. I appreciate that. I got a question here. Is a labiaplasty something that a fertility specialist would do? Well, so that is an interesting question, because labiaplasty, which means basically reduction of large labial skin, or basically reconstructing the outside portion of the vaginal area or the female genitalia, the labia, the lips, is something that I've done hundreds and hundreds of. It was something that I was sort of whether it's a functional or a cosmetic procedure, or something I'm very proud of, is something I consider myself an expert in. So I first, I did that really as started doing that as a general gynecologist, as just a gynecologic surgeon. But I learned that initially from a reproductive endocrinologist, because someone, when I was a resident, a patient who had a hormonal abnormality came to the reproductive endocrinologist while I was on that service, asking for a labial reduction. So that's in fact where I learned how to do it. So I think the question is not so much, is it, I think it's something that really any gynecologist has the ability to do. But the question is, how comfortable are they with it? And is that something that they've done a lot of? Because it isn't, it can be a very basic procedure, but to be honest with you, there is a lot of art and nuance to it, sort of just like having any other type of cosmetic surgery. You want to make sure that you're going to someone who is comfortable doing it. So not specifically reproductive endocrinology, I would say in general, experienced gynecologist, yes. Hopefully that helps you a little bit there. Another question here that came in: tell me about sperm morphology, and is it causing our infertility? All right, so sperm morphology means, what do the sperm look like under the microscope? So somebody's job is to sit at a microscope and look at sperm. Sperm have a head, they have a neck, they have a tail. What's normal for us, and this is just, I've mentioned this before, I think it's kind of crazy. What's normal for guys is that 96% of sperm can look abnormal, and that's entirely normal. In other words, a morphology rate of normal sperm, 4%, is all I expect when looking at a semen analysis. So honestly, that's one of the reasons that it takes 20 million sperm to get one sperm on target. One of the reasons is because 96% of them can look abnormal. And the other reason is that it may be only 40% of them are swimming. So a motility of 40% is a normal number. So that's why I think we are kind of so inefficient at the way we reproduce, why we need so many sperm when really it's just one sperm, that it takes one sperm to penetrate the egg, one sperm to get that job done. So morphology is, what do the sperm look like under the microscope? It's normal that 96% are abnormal and that only 4% are normal. So we know that a low morphology, which is known as teratospermia, is associated with subfertility. So what does that mean? It means that, couples who are having a hard time getting pregnant may come in and may have an issue with teratospermia, but it in and of itself is not a cause of infertility. Now, when I see persistent teratospermia, it makes me think about, is there an issue with the DNA fragmentation in that sperm. And what is DNA fragmentation? DNA fragmentation is where the genetic material that's in that sperm starts to kind of become unwound. And when the DNA becomes unwound, it means that that sperm may not really know what it's supposed to do inside the female body. It may get around the egg, it looks at the egg looks at it, and they're like, hey, how you doing? But it never really gets to the point where it knows how to penetrate that egg and fertilize that egg. So in men with a higher level of DNA fragmentation, typically that means that we will see sperm not so well able to fertilize the egg inside the body. So things like natural intercourse or even IUI, insemination, become far less effective. And so in that scenario, then we recommend that you take that sperm and you put it inside the egg, which is of course known as ICSI, intracytoplasmic sperm injection. And that's where you're actually placing that sperm inside the egg. That's the treatment for DNA fragmentation. So to answer your question, sperm morphology means what does it look like? Morphology alone is not considered to be a cause of infertility, but is certainly associated with subfertility. And one of the reasons for that likely has to do with this issue of DNA fragmentation. Zinni says, hope mom gets better soon. Thank you. Let's see, we've got Noodles here as well. And Aaron says, hi and thanks, and and then it stops. Aaron, you left me hanging there, man. What's up with that? Thanks for nothing, by the way. Thanks for nothing. Hey, what else is going on in your world out there? Let's see, got another sperm question here. And that is, well, this is a question that we've been asked before. My husband is not so interested in doing a semen analysis. Is it necessary for me to have to proceed with? Is it necessary for me to proceed with treatment? Is it necessary to have the semen analysis in order to get treatment? And the answer to that is pretty much, yeah, pretty much it is. And I would say, why is that? Well, because, in at least 40% of the cases, the issue is with the sperm. And some studies would even show us 50% of the cases, it's a sperm issue. And so if we don't know what we're dealing with, we don't know what there is to treat. Now, is it reasonable in general gynecology practice to allow some ovulation induction treatment before you've checked a semen analysis? Maybe for a couple of cycles, it probably is. If the patient, isn't ovulating, I think if we get you to ovulate, then maybe that's going to be enough to get you pregnant. But, in my specialty practice, if a patient comes in here, we will definitely do a semen analysis. We're not going to treat you without a semen analysis because we're the specialist and you come here to get pregnant. So we want you to leave here pregnant. We're not going to leave the I's undotted and the T's uncrossed. So is it necessary for the male to participate? Getting pregnant is, when you're in a couple, is pretty much a couple's thing. And so we really want both partners to be participating. Now, by that same token, sometimes, we here do semen analyses for members of the community. Referring doctors in the community will send patients here for a semen analysis. And, a lot of times we'll see a semen analysis that comes back maybe showing that there's no sperm or showing that there's some real significant problem with the sperm. And then the man wants to make an appointment because he wants to know, what can he do and what does this mean? Well, in that scenario, we say we want to see you both as a couple because it really is a couple's issue. And it's often something that we can solve together as a couple. So I hope that answers your question. MGB Loops, which must be, I can't see who the picture is there, but somebody who's friends with Ruby because Ruby says hi too. Hello. Noodles asks, how reliable is the BCL6 positive test results when I have no endometriosis symptoms? And that's a great question, Noodles, and it's something that we deal with really every single day in the fertility practice. So certainly Endometriosis, the classic presentation of endometriosis is pain. It's a pain syndrome. It can cause pain. It can cause scarring. It can cause decrease in your ovarian reserve. And it also causes difficulty in getting an embryo to implant. So the classic presentation is pain. It's very, very painful periods. And there's a high correlation to people who have painful periods and have that positive BCL6. But here's the thing. The most common presentation of endometriosis is silent endometriosis. It's the endometriosis that we didn't know was there until we went looking for it. So how reliable is a BCL6 positive test? I'd say it's pretty doggone reliable. If it came back positive, that means that marker is there. Now, I don't typically recommend that people do that Receptiva test unless you either A, have a high clinical suspicion of endometriosis, or you have repeatedly failed embryo transfers. In other words, we're putting embryos in and they're not sticking. If we're putting embryos in and they're not sticking, I would say, well, we're trying to figure out what's the reason behind that. We want to know, why isn't it working? And so in that case, we start going to look for endometriosis. So I would not go out there on the streets and select random people and say, hey, let's do this test, because the positive result is much more meaningful in a group who has either high clinical significance based on the symptoms, or those who have repeatedly failed implantation or had recurrent early miscarriages. That's when I start thinking endometriosis. And in that case, that test is very highly reliable. And what we know is it'll take let's say you have a euploid embryo, that ought to give you about a 65% probability of pregnancy. Well, that 65% number drops down to about 12% if your endometriosis test is positive. 12%. Damn right that makes a difference. So if we treat that, if we suppress that endometriosis for 60 days, your 12% number goes right back up to 65. In fact, even a little bit higher in the studies, maybe even up to 70%. So yeah, I do think it's a big thing. I think it's a very good test. It's a very meaningful test when used appropriately. So Noodles, I think you can feel, pretty good about that. Rosa asks, can the hysteroscopy or the saline sonogram happen while on Orilissa before doing an FET? And the answer is yes, absolutely. In fact, that's a really good time to do it, because we know that your lining is going to be nice and thin, that you won't have overgrown some normal hormonal lining in the uterine cavity there, so that it makes it hard for us to see. So therefore, if there is a polyp, if there is a growth, if there is something inside the uterine cavity, then we can say with confidence that, yep, it's actually real. It's really there. It's not something that's going to slough off, because even without that hormonal stimulation, that filling defect, as we call it, was there. So yeah, I think doing it either hysteroscopy or saline sono while on suppression, either with Orilissa or Lupron for endometriosis, is an awesome time to do it, in fact. Cat B825, I like the name. Nate's wife, Kayla. Hey, how are you doing tonight? She says, thanks so much for your insight. I have twins because of you. Oh my goodness. Wow. Oh my gosh. I want pictures. Will you please send me pictures to my Instagram? And that's Randy Fink MD. I want to see your twins. I will not post them unless you tell me it's okay, but I love to see those things. It just absolutely makes my day. To know that you can look at two beautiful babies that I was a part of bringing you. Thank you, Kayla. Hi, Amal. Nice to see you here tonight. Let's see. Kat says, can day 3 embryos be donated or only day 5 embryos? Typically, it's blastocysts. Typically, it's day 5 embryos, because day 3 embryos, we just don't know what's going to happen with them. We don't know if they would continue to survive. And so if an embryo grows to that blastocyst stage, we know it has a higher probability of being normal. And a normal, chromosomally normal embryo is what we need for that embryo to implant. So by the time someone is going to adopt embryos from you, they really are looking for something that has the highest probability of being successful. So I'm not aware of programs that will use donated day 3 embryos, cleavage stage embryos. But what you would do is simply grow it out to blast, and those that survived could easily be donated. Yeah, and that's a great question too there, Kat. Thanks for that one. Hey, guess what time it is? It's 5:30, which means it's time for the 5:30 Fuzzies with Fink. Half past the hour. And by the way, if you're just joining, my name is Randy Fink, and this is Fink and Friends. I am Fink. You are friends. And we're here like we are every Tuesday evening at 5 o'clock on the Gulf Coast to talk about fertility and all those things about getting pregnant and women's health and bringing on the family. I'm a fertility gynecologist at New Life Fertility in Pensacola, Mobile, and Panama City. We also home office here in Pensacola. And I also work with MCRM, Missouri Center for Reproductive Medicine in St. Louis and in Tulsa. But this is the time when we all get together and just take a moment to acknowledge every one of you out there tonight who may be struggling. The fertility challenge is one. Bailey, if you're still listening here tonight, I said this to you a little bit earlier. You have been poked in the eye a lot. And, there's only so many times you can get poked in the eye before you kind of go, you know what? I'm kind of tired of getting poked in the eye. And you flinch when you see somebody coming towards you. Enough eye poking, enough torture. Fertility is a rough road. We never really know for sure what the outcome is going to be, and that outcome may not be what we want for it to be. We may have to jump through 1,000 hoops before we finally get that baby of our dreams, or before we finally unlock the problem that's keeping us from getting there. And that roller coaster ride is one that's generally pretty unpleasant. I know that almost everybody who watches this program would give the shirt off their back to help someone else who is in need tonight, who is struggling, knowing that they're having a hard time, that it's not an easy process. The thoughts about giving up, the thoughts about, man, I wasted too much time, the thoughts about this is God's way of telling me it's not for me. And whether it's about fertility, or whether it's about work, whether it's about school, whether it's about relationships, whether it's about partners or family, no matter how frightened you may be, it's important to know that you are not alone. And at the 5:30 Fuzzies with Fink, we get together and stand together really as one community to send out those positive vibes tonight to everybody who needs them. Everybody who needs to hear tonight that you are not alone. We are here for you. And I'm here to say that tomorrow is a new day, and it's full of all new adventures. So slow down, take a breath, and know that your dreams are within your reach. If you want it to happen, it can happen. Your mind just has to be there. It's a battle sometimes to get there, but you're not doing this alone. Please push the little heart button. Send out some positive vibes to everybody tonight who could use a little extra heart in their life to know that they are not alone. And that, my friends, is the 5:30 Fuzzies with Fink. We're so fuzzy. Thank you for participating in that. If that's your first time hearing it, please ask your friends to come at, even if it's just 5:28 28 minutes after the hour next week, because what I really would like to see is kind of breaking the internet with kindness. There is not enough kindness in our world, and I really feel like we can change this world and make it a happier place to live and be, even if it's just one mind at a time, one heart at a time. And how can we do that? By knowing that what we do in this world really does make a difference for other people. So please, if you're not on the receiving end of the fuzzies tonight, but you feel like you're sending out those vibes tomorrow, do something special for someone. Change someone's world tomorrow, because that's really why we are all on this planet. We are here to make a difference. So let's do that together. Thank you. All right, that's my preaching for tonight. Hey, look who's here. Pooey is here. And Pooey, my friend, I have been meaning, I wanted to send you a message and thank you so much for such a wonderful evening you hosted us for last week in St. Louis. In Webster Groves, as I think is what that area is called. And I will say Pooey's Restaurant, which is known as Sushi Station, is one of the finest. Look, I've lived by the sea for, going on, 2.5 decades now, and have eaten a lot of fresh seafood. That sushi was the best I have had. That service was exquisite. That atmosphere was so laid back and casual. Your price list was amazingly fair for the quality that was. I honestly have never had anything like that before. Sushi Station in the Webster Groves area of St. Louis is a place that I will tell you is probably worth taking a trip to St. Louis for. I will be there again, but thank you for ordering for us. And thank you so much for making that such a special evening for me and Peter and Dan. Very, very much appreciated. And also the little pain patches are amazing too. I was going to send you a message and you beat me to it there, friend. Baby Love is here, and we've got Megan G, and we've got Amy Beth, and we've got Kelly Dixon and GPTV. Gosh, Thalis Bello, I think is what that says. All kind of over here. Bunch of different feeds. We've got my Instagram here. That's Randy Fink MD. We've got New Life Fertility's Instagram. We've got Facebook, YouTube, LinkedIn. We've got New Life Fertility, MCRM, and the First Fertility Network, of which we are proud to be a member. And you can find them on the internet at firstfertility.com. So what else is going on in your world tonight? So I got another question here. Does an ovarian cyst matter in my fertility? Well, that's kind of I will say, that comes from Sue Ellen. Sue Ellen, that's kind of a broad question because it might. So ovarian cysts can happen for a variety of reasons. And I see, very commonly people talk about ovarian cysts and say, oh, I have a history of cysts. And I say, okay, you're female. So yes, you do. So let's talk about ovarian cysts. I think, it's a great question and a wonderful segue to talk about some normal anatomy. So every single month, if you're female, every single month that you're not on birth control, your brain tells your ovary, give me eggs. And the ovary says, okay. And so it dips down into its well and it pulls up a bunch of little egg houses. And we call these egg houses follicles. A follicle is literally a little sac of fluid with a microscopic egg in it. And so we can look at your ovaries in the beginning of your cycle and we get what's known as an antral follicle count, which is prognostic about how your ovaries are doing, where you are kind of hormonally and what sort of response we might expect from you. We can even plot out that number on a little graph relative to age, and it really can give us some quantitative information. And so that is useful. So Under normal circumstances, those eggs start to fight with each other. They start to bicker. They pull each other's hair. They call each other names. And they scratch at each other because one of them is trying to claw its way um, to becoming the dominant egg or the dominant follicle. And that dominant egg is the one that goes on to be ovulated. So when you ovulate, so actually as that follicle grows, the fluid around it starts to fill up and the follicle gets larger. Many people call that a cyst. Well, if you call that a cyst, yes, you're right. It's a little sac of fluid, but it's physiologic. You have that cyst. As long as you're not on birth control, you develop a cyst like that every single month that you're going to release an egg. And when you release that egg, some people say, oh, I had a cyst that ruptured. Well, that makes it sound like there's something wrong with you or that something is broken. Of course it ruptures. It releases the egg. Some people have pain when they release that egg. Boop. The egg comes out. The fluid that was within it spills into the pelvis. So is that a ruptured cyst? Yes, technically, I suppose it is, but it's physiologic. It doesn't mean that there's anything that's wrong. Now, what happens when that egg leaves the ovary? It's like a car leaving a garage. It leaves behind an empty space, and your body hates empty spaces, and so it fills that space with fluid. Sometimes that fluid can be blood, and that creates what's known as a hemorrhagic cyst. And that cyst is what's called a corpus luteum. A corpus luteum is the tissue that's left over when the ovary releases its egg. And those little cells inside that corpus luteum, they were making estrogen in the first part of the cycle, and then they convert, they change over, and they become a little progesterone factory. And so that's what your corpus luteum is doing. But when you rupture that cyst, you're really just releasing an egg. And then it fills up with blood, so then you have a big bruised feeling ovary. Now, sometimes that corpus luteum can fill up with blood and it puts a stretch on the capsule of the ovary. The ovary is relatively inelastic. It doesn't like to stretch. And so when you stretch it, it hurts. You can feel that. And to make matters worse, there's a bruise actually inside the ovary, no different than if you got punched and you got a bruise on your arm or your leg, except that this one's in your ovary and it's liquid blood that then starts to clot and it turns all different colors and eventually your body reabsorbs that. Now, if you're actively bleeding into that space, it can then rupture as well. And sometimes it can keep bleeding. And that's what's called a ruptured hemorrhagic corpus luteum, and people can bleed on the inside from that. I've had to take patients, to surgery as a result of that, bleeding from a ruptured cyst. But most of those cysts are really physiologic. It doesn't mean, when someone says, I've got cysts, I say that's because you've got ovaries. It doesn't mean that there's something wrong with you. And that's an important thing to know. Now, when you ask, can the cyst interfere with pregnancy or can interfere with getting pregnant? The answer is it kind of depends on the type of cyst. So let's say that you are going to be starting something like IVF. Well, when you're starting an IVF cycle, we do a baseline ultrasound and we check some hormone levels, because if you've got a big follicle or a big collection of fluid that's in one of the ovaries, especially if it's already secreting some hormone, well, then, yeah, that's taken up some pretty valuable space that the other follicles are going to want to use when we try to get them to grow. So in that regard, yep, it may actually have something to do with making your cycle not work out for you. So it can matter then. A collection of endometriosis in the ovaries is called an endometrioma. And yep, that too, that can show us that you have endometriosis and can make a difference in things like pregnancy outcomes. There are cysts in the ovaries that are not functional cysts. For example, People can grow cysts in the ovaries that just aren't doing anything. They're just little collections of fluid. There's like a little sac of fluid in the ovaries. This is usually something that's called a cystadenoma. There's something called a serous cystadenoma. There's something that's called a mucinous cystadenoma. These are benign growths in the ovaries that will often grow and stay persistent over time. So if someone comes in to see me and has said, oh, I have a cyst in the ovaries, and we go and take a look, and yep, there's a cyst there. We follow it over time because we want to see if it will go away on its own. In many cases, if it's a functional cyst, if it's related to that follicle, that egg in the ovary, or a corpus luteum, it will resolve. If it is something that's persistent, those are things that we want to watch more carefully. So some small proportion of those can be something bad, but more often than not, they're benign growths. But if they don't go away, then we know they don't go away. And that's the reason people often think about having to have surgery on their ovaries to get that kind of cyst removed. Now, the one other thing I'll point out there is that another risk to having those big, larger ovarian cysts is that when one gets to be about 5 centimeters or larger, we start thinking that it runs the risk of potentially twisting on itself. Twisting on itself is what's known as an ovarian torsion. And what happens in that situation is that you think about a big Christmas tree ornament on the branch of a Christmas tree. If the ornament is too big, if the ornament is too heavy, it's going to pull the branch down, right? Well, if that happens on the ovary, it can actually cause it to twist. And if it twists, then it starts to choke off the blood supply that's going to that ovary. That becomes a surgical emergency. And it usually presents in most people as worst pain of your life. There is generally no ifs, ands, or buts that something is, if you have to say, oh, I just felt something. I remember him talking about a torsion. I wonder if there's no wondering about an ovarian torsion. It is, it's pretty obvious, really, in most cases. It's the worst pain of your life. It's the kind of thing that there really is no other choice but you take yourself to the emergency room because, you can't, not something really you can stand. That's a torsion. And so, typically what you do is you untwist the ovary and you try to get some blood flow going back in it. And that's something that can happen when a cyst really gets too large. But really, honestly, any ovary of any size can twist. But we particularly start looking at things and thinking about and talking with you about those risks when we see a cyst that's greater than 5 centimeters. So can something like that get in the way when you're pregnant? Well, what happens to your uterus when there gets to be a baby in it? Does it stay the same size? Nope. The uterus starts to get much, much bigger, obviously. Uterus grows. And as the uterus grows, the ovaries are really kind of part of that whole situation. The ovaries move, they raise up. They don't stay in their low spot, very down low in the pelvis where they're kind of nice and tucked in. And so if you have a big ovary, as the uterus enlarges with pregnancy, it probably does increase your risk somewhat of an ovarian torsion. So that's another reason that we might say, yep, that cyst can have some impact on pregnancy. So generally something that we want to kind of really keep a close kind of eye on. People also really ask about fibroids. And what is a fibroid? A fibroid is quite literally a ball of muscle in the uterus. So the uterus is made of smooth muscle, and these little muscle layers come together in sheets, and these sheets form themselves a little hollow organ. Well, a fibroid is when one of those cells gets a little knocked off kilter, and instead of forming a sheet, it forms a ball. Fibroid is literally a ball of muscle. Now, it's said that about 70% of women will have fibroids in the uterus, and it is not in and of itself a cause for alarm, or really, honestly, if 70% of people have them, it's kind of a normal variant. Many times these fibroids are very tiny. They're 1 or 2 centimeters. They're small enough that we really, they really don't do very much to you. And just because they're there doesn't mean you have to do anything about them. From a pregnancy standpoint, we start to get worried or start to think about, is this going to have some impact? If that fibroid is certainly within the uterine cavity, and that's what's known as a submucosal fibroid, or if it's within the wall of the uterus, and that's what's called an intramural, a mural fibroid, if it's within the wall. If it's within the wall of the uterus, by the time it's about 5 centimeters, we start thinking, it may have some impact on the blood supply to the uterus and may start to be able to affect the pregnancy or the implantation or something like that. You can also have a fibroid that's sitting what's called a subserosal fibroid, and it's more on the outside part of the uterus. So outside part of the uterus, the serosa is the outer layer. Subserosal means it's kind of just sitting on the outside part. Fibroids like that in pregnancy sometimes will outgrow their blood supply, which means the blood is feeding them. And they grow really fast, but they may grow so fast that they can't get enough blood to keep feeding them. And then usually from the middle, from the inside part of it, starts to die off. That can be a real painful situation. That's called a necrosing fibroid. It's the sort of thing that can also happen. It can happen in pregnancy or not in pregnancy, but certainly more likely in pregnancy because the uterus is growing. Let's see, who do we have here tonight? Mrs. Galliano, good evening to you. Hello, Tracy in South Florida. Thank you for being here. If you still are, regards to the kids and the cats. Cinti Creations. Is that Sherry? I wonder. Could it be? Is that Desiree? I don't know. I can't see the little picture there. SB Charles, good evening. Asking about the best CoQ10 and do you recommend NAD+? So I have not seen, and these are both supplements. I don't think there is necessarily a best brand of CoQ10, but the important part about CoQ10 is that you get the type that your body is going to absorb. So there are 2 types of CoQ10. One is called ubiquinol, and the other is called ubiquinone. Ubiquinone is the type that is in most of the supplements that you buy over the counter, and it is the type that your body has to convert in order to get it to be able to metabolize it and to use it. So if you're using the ubiquinone form, you need a total of 600 milligrams a day, which is usually at least 300 milligrams in a divided dose. Now, you can get it at 400 milligrams and take that twice a day. But if you have the ubiquinol form, it's only 400 milligrams. So that's a 200 milligram capsule. The most common thing that I see, and again, it's not so much an issue of brand as much it is a problem that has to do with people not getting enough CoQ10. They'll get the ubiquinone version and they'll take 200 milligrams of it. And I'll say, well, I suppose it's better than nothing, but the recommendation is either 400 or 600 milligrams of ubiquinol versus ubiquinone. So you just want to make sure that you're getting the right type. Okay, let's see what else. And you asked about NAD+. The thing about NAD+ is there is some evidence that it is Oh, sorry about that. I think I knocked all my lights offline. Oh, hello, he is back. There we go. All right, now we're back in business. NAD plus is really better when used IV. So the oral versions of NAD plus, I really haven't seen great evidence about its oral absorption or that it is particularly useful. Now, I've seen it in the form of drops and things that are absorbed buccally, like you put it like between under your tongue kind of thing. I think that's better than a capsule or a tablet. But really the best evidence of NAD plus is when used intravenously or as an infusion. I do think that CoQ10 is probably the most important supplement for you, SB, because we really know that at the level of the ovaries, it kind of does the maximum kind of a workload as it pertains to us being able to repair some of the age-damaged DNA in those eggs. So CoQ10 really important. Is NAD plus going to hurt? No, but if you're not, careful, you can easily find yourself spending, hundreds and hundreds of dollars a month on supplements that may or may not make a big difference. If you look online, gosh, there's so many people that swear by this and that and this and that. And, at the end of the day, you literally could be taking, shoveling handfuls of supplements that can affect your liver and can do not such good things for you and make you nauseated and ick. But I would say, there is absolutely an evidence-based protocol for what can a handful of vitamins do to help. And so I would look for that evidence-based protocol. And that's in my book, my little ebook, and that's the Vitamin Victory, which you can get by looking at my link on my Instagram, and that's Randy Fink MD. Click on that link, and that'll show you how to get that cheap little ebook, the Vitamin Victory. Let's see, Designing 101, and hello, David. Good evening. SB also asks about red light therapy. And, I think there's something to it, but it really hasn't been well studied enough to say exactly what there is to it and how to really maximize it. Because if you take red light and you shine it on your face, there is some studies that show it increases the production of hyaluronic acid. It may decrease signs of aging in the face. And so, gosh, that sounds like a good thing to do for your ovaries. Problem is, how do you get it in there? If you're just shining it on your belly button, is it going to get into your ovaries? I don't know. I am cautious about that, but I think there probably is something to it. We just haven't really learned exactly what to do with that. And one last question. She says, the cavity is great, but still failed. Okay, well, so what the uterine cavity looks like is only a small piece of the overall puzzle. The bigger issue is not so much what the uterine cavity is like, but rather what was the embryo like. It is much more commonly an embryo issue than it is any issue with mom. So embryo would be number one. Uterine lining and receptivity and things like endometriosis would be number two. But most important thing is, what was the embryo like? You can have an absolutely beautiful, perfect uterus, and a perfect lining and be hormonally perfect, but have an embryo that isn't chromosomally normal. And despite the best efforts, it's not going to stick. So I always wonder about embryo. And with that note, folks, we are going to be out of time tonight. I want to send very special shout out again to all my friends who were able to join tonight. Thank you, Rosa, SB Charles, always a pleasure. Bailey and Cameron, thank you so much if you're still on for watching all the way in Great Britain. Thanks to Angela, and I just saw your message here. I missed that, so sorry about not answering. But many thanks to everybody. And I didn't get to see. Oh, here was Jessica over here. I didn't get to answer your question, Jessica, and I'm sorry because this camera was covering it up there. But we'll try to get that. We'll get that one next week. How about? Hey, next Tuesday at 5 o'clock is the time to join Fertility with Fink and Friends. 5 o'clock on the Gulf Coast, which means 6 in the East and 4 in the mountains, 3 on the West Coast, because this fertility business is not the book of your life. It is just a chapter. And what are we doing? We are here to rewrite it together. So let's do that every day forward with love, every day forward with kindness. Do that kind thing tomorrow. Change someone's world. Make a difference. And every day forward with hope. Because tomorrow is a new day and it is filled with all new adventures. So until next week, live from Pensacola, I'm Dr. Randy Fink. Thanks so much for being here. And good night. See ya. There we go.